of more questions at the end. And so we go to the next speaker because we're a little bit out of time. The Professor Nobuyuki Shimokawa from Japan. Please connect. You can share your screen. And we have already some questions in our chat, and we'll just ask all the participants them later. Thank you very much.
Can you hear me? Can you see me?
Yes, we hear you. We hear you. Yes, you can start your presentation. Thank you.
Okay. Okay. My topic is a posterior surgical technique. This is a photo. I was a member of WS Spine Committee from 2013 to 2008. This is a memorial photo in Russia. In
Can you please make it whole page? We see.
Yes. Press, please. Yes, play the presentation.
What?
The slides are not moving. We see only all the slides together.
All slides together.
Please click the whole page button on the right bottom place. Whole page.
Bottom.
Full. You can select the button, full presentation button.
Good.
It's okay. You can see?
No.
No.
Yeah, now it's okay.
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 Yeah.
Okay. Hey. Surgical indication for cervical OPLL. There is no evidence to recommend preventative or surgery for asymptomatic or mild cases. A good indication is a progressive type, including a rapidly or slowly. A relative surgical indication type is a large OPLL type and combined canal stenosis. This is K-line, as you know. K-line plus is a good indication for laminoplasty. In 2020, this paper shows surgical decision-making for cervical OPLL. Anterior approach is a K-line minus OPLL, and K-line plus and large OPLL. Posterior approach, K-line plus OPLL, and small type OPLL, and multi-level combined pathology, more than 3 levels. This is my case, is a CSM case. Posterior decompression, and 3 years after, the kyphotic changes occurs, and the patient deteriorated. But point of the kyphotic change of after laminoplasty is a chronic compression of ventral region of spinal cord. It means a compression of the anterior or spinal arteries. So decreased blood supply is related to the denervations. Among spinal surgeons in the 2010s, attention began to be paid to T1 slope and post-laminoplasty kyphosis in CSM cases. Like this paper, more than 25-degree T1 slope. In this paper, more than 26.5 degrees. In this paper, more than 29 degrees of T1 slope. And this paper has a strong correlation among the T1 slope and C27 SVA. And operative not only T1 slope, but also T1 slope minus cervical lordosis and cervical lordosis per T1 slope in CSM. This is T1 slope. This is C27 angle. So cervical lordosis per T1 slope indicates the tilt. And in this area is a good coordination. And 2022 from Japan, about the cervical OPLL, the SVA was also focused. This is vertical line. This is a C7 posterior or cranial point, and this distance A indicates the CSVA. So this paper was a retrospective studies. Anterior decompressive fixation case is a 28. PDF means a posterior decompressive fixation and laminoplasty. All laminoplasty cases were belong to K-line plus cases. High SVA group and laminoplasty group shows the postoperatively kyphotic change. Again, high SVA and laminoplasty group shows the kyphotic change and related to the lower recovery rate. In these cases, shows all mixed type OPLL, large SVA, and elderly patient. This manuscript concluded these patients should be went not only posterior decompression, but also posterior fixations. In 2016, in these papers, PDF should be recommended for large SVA cases. Here's Sakai. In 2016, he proposed a K-line tilt. This line is vertical line, and this is a K-line, and this angle named K-line tilt. In 2023, Sakai proposed the K-line tilt is a predictor of postoperative kyphotic change after laminoplasty or OPLL. Kyphotic change group shows the high K-line tilt and large SVA and large C7 slope and lower recovery rate. So the author concluded K-line tilt more than 20 degrees was a risk factor of postoperative kyphotic change after laminoplasty for K-line plus OPLL. In 2019, Dr. Bajiri reported the review about the OPLL progression after laminoplasty. More than 50% cases has the OPLL progression after laminoplasty. This is a Chiba paper. Chiba, as you know, is a student of Hirabayashi Keio University. They emphasize that cervical OPLL expands in the early period after laminoplasty. This indicates a strong relationship between motion stress and OPLL progressions. PDF. In 2016, from Japan, they calculate the volume of OPLL, compare the laminoplasty group and the PDF group. Result, left side is a PDF group. Right side is a laminoplasty only group. You can see the suppression effect of PDF, of progression of OPLL. This is my case. K-line minus and B-cut type OPLL. 68 years old man suffering from a progressive motor weakness. The patient had a not so bad whole spinal sagittal alignment. So the patient underwent kyphotic posterior or decompressive fixation surgery using pedicoscope. I left the anterior or large space for future additional anterior approach to the OPLL. Fortunately, the patient improved 1 year after and 5 years after. CT scan showing the this is a big portion of the OPLL. 5 years after the CT scan shows the flattening of the surface of the OPLL. Like that. Division surgery for OPLL. In 2024, from Korea, in this case, big type mobile segment, the patient underwent just posterior decompression. But 2 years after initial operations, the patient deteriorated. That's why the patient underwent anterior decompression directories. In these papers, the authors divided second operation plus group and minus group. Plus group showed the range of motion, large range of motion of OPL or level. So the authors emphasize mobile segment and big OPL are risk factor. In 2007, this is my case, 42-year-old man suffering from progressive motor weakness. You can see the small OPLL and combined protruded disc hernia like this, C5-6 level. The patient underwent the partial vertebrotomy and grafted bone and fixed cylindrical cage corner to corner, named Homma method. Just post-operative radiograph and MRI showing a good position of the under decompressions like this. During 2 years after operation, the patient good recovery, but the patient complained neck pain and neurologically shows the C5 palsy of the right side. At that time, dynamic X-ray, you can see the minor instability at C4-5 and subsidence change of the iliac bone grafting portions and non-unions. Right side VA spontaneously occluded. It may be due to arteriosclerotic change of the severe diabetes mellitus. So I selected the posterior cervical fixation using the pedicle screw right side of the occluded side, and the lateral mass screw is the left side, patent VS side, and the posterior decompression of the foraminotomy of C5 nerve root. After the operation, the patient's neck pain disappears, and C5 pulse improved. 5 years after, good bony infusion obtained, like this. Progression ratio of cervical OPLL. This is my case. During 70 years, cranial directions 1.2 millimeter per year. Caudal direction 0.3 millimeter per year. Thickness 0.3 meter per year. Don't forget, OPLL is a progressive disease. In conclusion, currently, when performing posterior decompression surgery for cervical OPLL, the pre-operative radiological evaluation should focus on SVA, mobile segment, and K-line tilt. After posterior surgery, attention should be paid to kyphotic change, OPLL progression, and mobile segment. Thank you for your attention.
Yeah, thank you. And I ask my moderator to continue.
Okay. Okay. Now we can start the discussion. If you have any question.
Inviting me on this very important symposium. And I think the previous speaker, they have given a tremendous amount of knowledge and insight into the OPLL and the related issues. My question is with Oscar, do you have any dural tear or dural damage when you go for anterior side? You just remove the OPLL. OPLL is very densely adherent to the dural, and or you just thin it out and let it float off from the sac.
Please, you can activate the.
Thank you for the question, Tariq. I do not advise to remove the OPLL. I think what I do is the anterior floating technique, where with the drill, with microscope, you just thin as much as you can, and then you release on the sides, and then you see the expansion of the dura. Yes. I find the Zen technique very elegant, very difficult, but I'm afraid of doing it when you pull everything on a block and you don't see what you are pulling. You don't have a direct control of the situation.
And now
I'm much more confident in my technique with the anterior floating technique, which is, if you are a trained surgeon using a drill, you can do a very good job of decompression without risking CSF leak.
Okay.
Anyone have a question?
Yes. Anyone has a question?
I have a question from the chat. I can read them. So the first question was about repairing dura. If you have dura trauma during the anterior approach, how you can do this. So this is to all the talkers. So this is from the chat. All the lecturers can answer it. Oscar, if you have a dural damage, what are you going to do?
The first thing to know is a dural tear in anterior cervical spine is not as bad as a dural tear in lumbar spine, okay? The flow of CSF is much smaller. So normally what I do is just use some sort of patch and glue, and most of the time will go away. Of course, if it is a high flow fistula, you would supplement with a lumbar drainage for some days and watch how it goes. But generally, it's not as complicated, as difficult to manage as and anterior repair. It's not easy, especially in the setting of OPLL. It's quite complicated. But that's my general approach.
Okay. So we have another question from the chat. What is the rate of recurrent of OPLL? Rate of recurrent.
I think with anterior techniques, the ones that tackle the OPLL, anterior floating or Zen technique, the recurrence rate is really, really small. Whereas if you go posterior, if you do a laminectomy alone, that's the worst scenario. It can be almost 2/3 of the patient. If you do a laminoplasty, almost half of the patients, the OPLL will grow. And if you do a fusion, that's the best scenario, around 30% of regrowth of the OPLL. These are general numbers.
Yes.
I think Nobuyuki can answer that question better. And he paid attention that it is a progressive disease. If you leave the OPLL, it progresses. We know it well. What is the recurrence rate, Nobuyuki? What do you think?
Thank you. The progression of the OPLL is a much important issue for the patient and the surgeons. Just posterior decompression is indirect decompression. That's why I should take the multi selection and technique we surgery should have, and depend on the cases and the level of the OPLL, we should select the selection of the approach.
Okay. We have one more question from the chat. The question is about Artur Goel technique, that he recommends only fusion during the OPLL. What is your, and he thinks that the compression is not necessary. What do you think about it?
I think the best guy to answer this question is Mehmet. I heard Mehmet giving a wonderful lecture on the topic in front of Atul in India. So Mehmet, please.
This is a good. Actually, Atul was with us. Are you here, Atul?
Yes,
Atul
I'm
has
here.
connected.
Oh, great.
Hi, how are you? The question is for you. Actually, one of the participants is asking the value of only fixation. Would you like to say something?
No, as you know, I'm absolutely convinced. I have no doubt. And I'm talking now on the basis of a very big experience that there is no need to do a very extensive decompression or any kind of decompression. Only fixation is the treatment, and magic is the clinical result. It has to be just seen and believed. It is not, when we see images, when we see the MRI, we see the huge compression and cord getting compressed, and it is, nobody can believe that such compression you don't have to decompress. But you just do fixation without any kind of decompression from front or from behind. Mehmet, as you know, I have been talking about this for a long time now. I'm sure, I'm convinced that this is the future of the treatment.
Okay. My comment on this issue is I have explained in Atul's meeting in Mumbai. Yes, fixation helps to stop the progression of OPLL. Because of that, I prefer laminectomy plus fusion surgery. Because of that, especially in the younger patients, because the progression of the OPLL is a very long duration process. The second thing, making no decompression and only fixation is not very well validated yet. Actually, although Atul presents very nice results, we need comparative studies, multi-center studies to learn the outcomes of those patients. This is my response.
Thank you. I have the question to all the participants also. What do you think of role of neuromonitoring during this procedure? Somebody use neuromonitoring?
Yeah, actually, I do sometimes, but we also did a very detailed study on the value of monitoring in cervical myelopathy patients, and we found that it's very valuable in cases to prevent C5 nerve palsy. Yes, especially EMG monitoring of the deltoid muscle. But we did not find very significant differences if we monitor MEPs of lower extremities or SEPs of lower and upper extremities. We did not find significant differences in outcomes in monitored patients and non-monitored patients.
Thank you. Any more questions? Somebody want to ask more questions?
So Nikolay, I wanted to ask to do Zen chain, and he has very nice technique, anterior techniques. And I wonder about micro decompressions, and sometimes we make corpectomy under 2 levels if there is a OPLL. but he make a lot of levels with anterior and only micro decompressions. And Professor Zan, do you compare with micro decompression and corpectomy? What is the differences for results?
Excuse me. You mean ACF and ACCF between the difference?
No, I want to know about you make multi-level microdiscectomy with anterior level. In these cases, we select sometimes posterior approach for with laminoplasty or laminectomy, but you made 3-level, 4-level with anterior and for microdiscectomy. And I think it is useful again because you use these techniques. And I wonder about differences when you select posterior and anterior multi-levels, and how's your results for all of the anterior when you compare posterior approach?
Yeah, I understand. And in the beginning, when we begin this technique, we use the technique to treat most of cases of patient, whether the K line is positive or negative. And I found that most patients can get a much better result than posterior approach because the axial pain is we worry about the posterior approach. And in the anterior approach, it's minimal invasive, though we furred several levels, but the approach is minimal invasive. The patient recovered very quick after operation. But anterior approach, we will need cost more time and more surgery times. So sometimes after several years later, if the K line is positive, now I would like to perform posterior approach laminoplasty much better. And if the K line is negative, then we choose anterior approach ACF to treat the patient.
Thank you.
There's one more question. I see the raising hand also.
Yeah, Jalal Najar. Yeah.
Yeah, good evening, and thank you all for your kind presentation and great information. My question is, if half of the cases will be deteriorated by observation, why we did not recommend surgery for asymptomatic patients? The second question, if we do a posterior approach for laminectomy and plus fixation, we should make our screws and fixation before do our laminectomy, as I understand. And thank you all. Is my question clear?
Yes, I think Dr. Zileli can answer this question. Dr. Zileli, do you think that
I'm not the speaker, actually. The question goes to the speakers.
But you suggest that the laminoplasty and the fusion could be together to prevent the progression of the OPLL?
Yeah.
So that's why the participants ask this question.
Oscar, what would you say?
I can add, starting from the last question, which is a technical question. What I normally do on laminectomy and fusion, I remove the spinous process, and this gives me the possibility to do medial angulation, lateral angulation of the lateral mass screws, which is the next step. And after the construct is done, I do the laminectomy. So that's the sequence of my surgery. And the first question.
High-speed drill. by high-speed drill, not by Carrison, of course.
No Carrison, drill all
Yeah,
the
that's
time.
it.
You thin it as much as you can, and then you just leave a thin shell of bone, and then with a 2mm Carrison, you take it out. And it comes as an unblocked lamina. And the first question, sorry, was?
Was it in why we did not recommend prophylactic surgery for the patient with severe stenosis had no symptoms, as half of the cases will be deteriorated by time.
Right. So, as I showed on that epidemiological study, the current situation is most of the patients are offered an operation very late. The mean JOA was 11 and for surgery, and the mean JOA of those patients on that cohort was 9, which is too late. So we need to make an effort to operate those patients. But on the other hand, it doesn't mean we should operate everybody. And we know that most of the patients have stable OPLLs. And if they are asymptomatic, it's nice to give them advice so they can look at symptoms themselves, schedule visits, once in a while, repeat an imaging. And I don't think you should operate on asymptomatic patients, truly asymptomatic patients, even though we know that there is a little bit higher risk of spinal cord injury in OPLL patients. I think if you educate them, it's quite reasonable to do instead of prophylactic surgeries. That's my understanding and what I found from the literature.
Yes, mild. The patients with mild symptoms or without any symptoms can be just advised not to have a major trauma, but otherwise just follow up. So there is a conservative management the sentence, but it's not very well understood what is conservative management in those cases. But just follow the patients without any symptoms with severe stenosis. Even there is a T2 hyperintensity, you can make it. But by the time if a radiculopathy happens, like a arm pain only, then we must recommend surgery.
I agree.
Same. More questions?
Yes, my question about the reperfusion injury. So anyone has a experience about the duroplasty after the compression?
Well, Serdar, there are many myths in spine surgery, like in brain surgery, and I think this is one of them. I could not identify a single case where I had this problem. And, all the complications or the neuro complications that I had in the past, I could identify what was the problem, what was the technical problem, the bad maneuver that I did during the operation. So I'm not sure this is one of those topics that we know it, that exists from lab, from animal work, but I'm not sure this is as prevalent as it is described in papers, especially in older papers. I think most of those situations are kind of situations where your technique was not 100% reliable. That's my understanding.
Okay, thank you very much.
I think it was wonderful presentations. Were very interesting for me. For example, the technique for anterior decompression was very interesting. I think I will going to use it in the future. And I want to thank you all the participants, all the lectures. It was really very interesting topics we covered. And I want my co-moderator to finish, please.
Yes. We together thanks to all authors and all presenters and also all participants. I think that the cervical myelopathy still has some controversies regarding the surgeries in terms of the posterior anterior approaches regarding the clinical results. So that's why still we will discuss the results of the techniques in the future. Thank you.
Thank you all the
professors.
participants for being with us. Goodbye.
Thank you.
ma-
Take care.
Bye.
Thank you all.
See you
Bye-bye.
soon.
Goodbye.
Bye
Thank
bye.
you.